Good evening to all doctors. I would like to thank you all for taking out your precious time from your busy schedule. This webinar is organized by Banai Behavioral and Neuroscience Academy of India. Banai is not-for-profit organization formed in 2012. Banai has organized 200 plus programs nationally and internationally. Focus of Banai is to provide contemporary cutting edge on behavioral neuroscience. Banai is formed and runs under the guidance and chairmanship of Dr. E. Mohan Das. Banai welcomes everyone and anyone who is interested to join. It gives me immense pleasure to introduce Dr. Ashwin Mohan as the moderator for today's webinar. Thanks, Dr. Ashwin Mohan, for accepting to be the moderator for the webinar. Dr. Ashwin Mohan is a senior consultant psychiatrist practicing at Chandigarh. Dr. Ashwin Mohan has completed his MD from PGI Chandigarh in the year 2000. Dr. Ashwin Mohan has also completed his postgraduate diploma in medical law and ethics from National Law School, Bangalore in 2016. His main area of interest are substance dependence, mental health law and policy, forensic psychiatry, and advocacy. He has held numerous posts in various organizations. I would now request Dr. Ashwin Mohan to take over and start the session's proceedings. Over to you, Dr. Ashwin Mohan.
Yeah. Thank you, Seshan, and thank you, Banai, for this opportunity to become the moderator of this webinar on evidence-based treatment of cannabis dependence. I'd like to introduce our chairpersons for today. Next slide, please. Dr. Ravi Kumar. Dr. Ravi Kumar is the senior consultant psychiatrist of Regency Group of Hospitals in Kanpur. He's done his MD psychiatry from KGMC Lucknow and an ex-senior research officer in psychiatry from SGL, ex-honorary IIM Kanpur and ex-president of Central Zone Indian Association. Next slide. Dr. Sanjeev Saoji. Thank you. Dr. Sanjeev Saoji is the professor and head of Department of Psychiatry, GMC, Government Medical College, Aurangabad. He is the president of IMA Aurangabad and honorary psychiatrist at Dr. Hegdevar's Rugnalaya, founder of Omkar Balwadi and Omkar Vidyalaya, and member of Board of Studies, MGM Universities. I welcome both the chairpersons for today's webinar and hand over the mic to them, and they would introduce our speaker, our eminent speaker, Dr. Atul Ambekar, and after which we can start the webinar. Dr. Ravi, please.
Good evening, everybody, and thank you, Dr. Ashwin Mohan, for giving me. Today's topic is evidence-based treatment of cannabis dependence, and we will be having the questions which will be asked by the audience, and the best question which will be asked will be given an award of 5,000 Amazon points, and winner will be announced at the end of the program today. So please post your questions in the comments box so that you are entitled to be examined. Thank you, audience. And after this, we are having a very eminent speaker today, Dr. Atul Ambekar, who is an expert and working at AIMS Delhi in the field of substances. And today we are having a very important area where we will be discussing about the evidence-based treatment methods in the treatment of cannabis dependence. Now, as such, the cannabis dependence or the consumption of natural and synthetic cannabinoids is increasing all over the world. and it is the only illicit drug which is more popularly administered all over the world. And when it comes to the treatment, it is very important because the cannabis dependence is associated with lot of psychiatric morbidities, comorbidities with the persons who are addicted to cannabis substance. And there are various methods available for the treatment, both psychotherapeutic and psychopharmacological methods also. But still, we are lacking in finding an appropriate method or a group of methods for all the individual patients because they have their own kind of problems and own kind of dependence on the cannabis or comorbid psychiatric illnesses. So, lot of work is going on in the field of evidence-based methods uh, to finalize that which method is more appropriate. There are pharmacotherapy methods also in the form of, say, cannabinoid receptor agonists, antagonists, GABAergic substances. Similarly, psychotherapeutic uh, methods where CBT and multidimensional family therapies and motivational talk therapies. There are various methods. I will not like to go into the details of various methods or treatments because Dr. Atul Ambekar is with us and he is an expert in the area and we will be getting more knowledge by his learned experiences. So I give the mic to my co-chair person, Dr. Sanjeev Saoji, who is also a very learned psychiatrist. And I will request him to kindly introduce Dr. Atul Ambekar to the audience, although he does not need any introduction, but there are many younger crowd in the audience. So I will request him to please introduce Dr. Ambekar to the audience. Thank you very much.
Thank you, Dr. Ravi.
Over my mic to Dr. Saoji.
Yeah, thank you, Dr. Ravi Kumar.
Yes.
It's my pleasure to be a chairperson in this important webinar. Now, we have a very important subject for this webinar, and it's of good fortune that we have the best speaker for this topic, Dr. Atul Ambekar, MD. He is Professor, National Drug Dependence Treatment Center and Department of Psychiatry, All India Institute of Medical Sciences, New Delhi. He is also chairperson of the Addictive Disorder Specialty of the Indian Psychiatric Society. He is Secretary General of the Addiction Psychiatry Society of India. His areas of interest include epidemiology, training, and human resource development, harm reduction, and opioid substitution therapy. He has authored a number of practice guidelines and training manuals. So you can see that we have the expert who is going to talk to us on this important topic. We can say that it will come from the horse's mouth. So I hand over the mic to Dr. Atul Ambekar and request him to start his presentation.
Thank you very much, eminent chairpersons and the organizers of Banai for giving me this opportunity. I have been asked to talk about evidence-based treatment of cannabis dependence. The topic is really interesting and made more interesting and challenging because the evidence whatsoever for treatment of cannabis dependence remains as meager as it could get. In fact, among various kinds of substance use disorders, perhaps the most struggle the scientific community has faced is for finding evidence-based treatment for cannabis dependence. And we will go into some of those issues also as we go along in this presentation. I hope my slides are visible to everyone.
Yes, they're
Right.
visible.
Right. Thank you. So, cannabis, as we know, is one of the oldest psychoactive substances and which has been sourced from plant. The plant has more than 60 active compounds, but these days, like everything else, the humankind has been able to synthesize cannabis-like substances through
Dr.
synthetic.
Atul, can you put the mic closer to your? We are not able to hear.
Right. Is it better
Thank you.
now?
Yes.
Right. Thank you. So, in this cannabis plant also, it's the female plant which is more potent than the main plant. And as many of us know, the main psychoactive substance in cannabis is delta 9 tetrahydrocannabinol, more popularly known as THC. As we can see here, there are quite a few cannabinoids in marijuana, but out of which the most substance of interest is tetrahydrocannabinol. This concentration of tetrahydrocannabinol is also different in different parts of the plant. So it's the flowering tops which has the highest concentration, followed by leaves, then seeds, and then stem. Various forms of cannabis are known: bhang, that we very commonly use in India, marijuana, hashish. People use it through various ways, such as hand-rolled cigarettes, making joints of them, making bong. Vaporizers are one of the newer methods of consumption of cannabis, and of course, oral route. In the Western countries, they are making brownies or cookies. In India, we have been consuming oral cannabis in the form of thandai or bhang ke pakode, or adding it into various sweets and mithais for a very, very long time now. Interestingly, the cannabis plant, besides generating the products for psychoactive consumption, has many other industrial usages as well. Cannabis is a source of excellent fiber, the hemp fiber. In fact, in olden times, the ships which used to go for voyages used to have their sails made up of hemp fiber. It's supposed to be very good quality fiber, and that's one of the untapped areas of cannabis. But coming to the epidemiology of cannabis use, as the chairperson also rightly said in the beginning, is the most commonly used illicit drug worldwide. But here is that important piece of statistic which we must see from the 2016 World Drug Report. While 183 million people reported using cannabis globally, out of them, a very small fraction, 13 million, reported using it in a disordered pattern. So, which means many people may be using cannabis, but cannabis dependence is not so frequent. When it occurs, it does share many similar characteristics with other substance use disorders, including various psychosocial consequences. However, it's a very established kind of conclusion that cannabis use causing dependence is much rarer as compared to some of the other substances. As a evidence, we have this piece of data which shows how very few people, a very small minority of people using cannabis actually meet the lifetime criteria for dependence. It's also important to understand that what's the total share of burden of disease caused by cannabis dependence. While this statistic is very much mouthed, very much reported that cannabis is the most commonly used illicit substance, we can see here what a small proportion cannabis use disorders lead to the total burden of substance use disorders. So as we can see here, the lion's share is actually of alcohol use disorders as a single substance. Among the drug dependents, it's cannabis causes or is responsible for less than just about 10% of global burden of disease. So we can see here that cannabis may be used by many people, but cannabis use disorders is experienced by a small minority. And even when people suffer from cannabis use disorders, perhaps the severity or disability is not as much as compared to other substances. So this is something we should bear in mind from the public health implications of cannabis dependence. In India also, about 2.8% of the Indians, which means around 3 crore people, they report using cannabis. However, we must remember, in India, when we consider statistics of cannabis, we include bhang as well. While at the international level, since bhang is not a controlled substance, they report only the consumption of what we in India call as charas or ganja. And as we can see here in this graph, in India, while the prevalence of use of bhang is higher than that of ganja or charas, the prevalence of use disorders is much higher for ganja and charas. Why? Because as we know, ganja and charas are much more potent forms of cannabis. And that's why overall in the country, if we see the number of problem users, bhang users are around 40 lakh, while charas ganja users are approximately 50 lakh. Simply showing the difference in the potency of charas ganja vis-a-vis bhang. It's also interesting to see the state-wise variations in India in the use pattern. The general trend overall in the country is that there are more people using bhang than ganja or charas. However, in the eastern parts, particularly West Bengal, Bihar, Sikkim, Mizoram, Nagaland, Meghalaya, there are more people using charas ganja than using bhang. Possibly there are socio-cultural pattern which is responsible for this. In the northeast, there is no established cultural pattern of use of bhang, which is associated in North Indian Gangetic plains. And in Bihar, it's the alcohol prohibition actually, which may be resulting in these kind of statistics. We must also look at how India fares as compared to the world. And as we can see here, our cannabis use prevalence is much lower as compared to rest of the world. There are a lot of policy issues responsible for this. Why? Cannabis is much less in India and opioids are so high in India. Today is not the time to go into that, but we must remember this also, this kind of statistics also, that the major problem, major burden around the world is caused not so much by cannabis, but by opioids, and for which we have much higher prevalence in India as compared to cannabis. With this backdrop, we come to a brief discussion on the neurobiology of cannabis. Interestingly, many people claim, rightly so perhaps, that we, the humans, have perhaps been destined to use cannabis. Why? Because we do have an endogenous cannabinoid receptor system. Mother Nature has given us the facility to consume perhaps and enjoy the effects of cannabis. So there are two types of cannabinoid receptor systems, CB1 receptors and CB2 receptors. CB1 is actually responsible for the psychological as well as some of the cardiovascular effects, while CB2 actually is involved in the immune system and inflammatory response. This is the distribution of CB1 receptors in the brain. We can see those areas highlighted here in the brain where CB1 receptors are found in abundance, and CB2 receptors are found in many other parts of the body. We are not going into those details here, but what we need to understand is that the psychoactive effects of cannabis actually are very complex, and a variety of neurotransmitters and brain circuitry is involved in the neurobiology of cannabis. So the endocannabinoids and CB1 receptors in rat amygdala and hippocampus have been reported to modulate the emotions. THC is known to selectively activate dopaminergic neurons in the ventral tegmental area, perhaps which is responsible for the reinforcing effects, which is responsible in turn for developing addiction. It also acts synergistically with opioid system, which is perhaps responsible for some of the analgesic properties of cannabis. Cannabis has also been implicated to deal with the GABAergic and serotonin system. Hence, there are implications for migraine management, and because of acetylcholine systems, it may have its role in the dysfunction. So there are medical uses of cannabis which are of much interest these days. So there are unique properties in cannabis which make it very good potential agent. Potential, I am saying, not proven as yet, but for many chronic pain conditions, glaucoma, cancer, cachexia, and HIV, and other kind of immunocompromised states, to improve the appetite, to reduce the vomiting. All these are good kind of indications where the research is ongoing and some of the results are really promising. There are anti-epileptic actions also, reducing spasticity, some anti-anxiety action also. These are, however, not focus of today's talk. But what we need to also appreciate is the growing understanding that the neurobiology of cannabis perhaps is slightly different in occasional recreational users versus the compulsive, habitual, or dependent users. In case of recreational occasional users, the ventral stratum or medial prefrontal cortex which have been implicated, while for long term compulsive habitual, the typical dependent users, it's the dorsal stratum and lateral prefrontal cortex which have been found to much more responsible. So in fact, in this diagram, this very interesting diagram, we can see the different shaded areas of brain responsible for different phases or different aspects of cannabis dependence. So it's the basal ganglia much more implicated in the binge or acute intoxication. For withdrawal or negative effect, it's the extended amygdala, while the prefrontal cortex is perhaps more active for preoccupation or anticipation types of effects of cannabis use. I will not go into too many details to bore you down because we need to move to the treatment also. But what I wants to highlight here is that since these various effects of cannabis, binge or intoxication or withdrawal or preoccupation and anticipation, there is a role of various other neurotransmitter systems. And that's perhaps the theoretical basis for trying out various medications which affect these neurotransmitter systems to see whether they can modulate, they can make a difference in patients with cannabis dependence also. Perhaps whether by modulating, making some changes in these neurotransmitter systems, perhaps we can make some changes in the symptoms experienced with cannabis dependence also, such as withdrawal or craving and so on. Which brings us to the management of cannabis use disorders. Treatment options, as chairperson also rightly pointed out, there are a variety of non-pharmacological and pharmacological treatment. In fact, because of the paucity and poor evidence of most of the pharmacological treatments, most treatment guidelines have been sort of forced to resort to suggest non-pharmacological treatments as the preferred treatments. So among the non-pharmacological treatments, as was rightly pointed out, cognitive behavioral therapy, motivation enhancement therapy, contingency management are the kind of approaches which have been found useful, particularly for adults. In adolescents, people have tried various other kinds of therapies as well. There is some evidence based with moderately good quality of randomized control trials also for motivation enhancement therapy with decent sample sizes for many of these. So I'm not going into details, but RCTs exist for different kinds of psychosocial interventions, such as motivation enhancement therapy, cognitive behavior therapy, and contingency management. In general, the understanding which is coming from the interventions, non-pharmacological intervention trials, is that perhaps a combination of psychosocial interventions works better than a one single psychosocial intervention. But of more interest to this group perhaps is the pharmacological treatment options and what is the evidence base regarding that. That's what now I'm going to highlight in next few slides. This evidence base for pharmacological treatment has come from a wide variety of studies. First of all, there are human laboratory studies, some open label trials, and of course the gold standards, the RCTs. About the human laboratory studies, just a few words here. So the idea in human laboratory studies is to monitor drug usage while it happens. So human laboratory studies are actually experimental designs, but they are typically done in a population which is drug dependent, but not actively seeking treatment for drug dependence. They are not really those people who are motivated or say, I want to stop drug use. The idea here is people who are drug dependent, continuing taking drugs, we give them some medicines as volunteers and see what happens to these medicines. That's the idea here. To basically the purpose is to generate some initial understanding, perhaps an hypothesis, which can then perhaps be tested through well conducted large scale randomized control trial design. So these are typically, as can we understand, small scale, cost effective, but the kind of evidence they generate is really preliminary in nature. So in these human laboratories, with the antagonist approach of cannabinoid receptors, people have tried various kinds of agents such as rimonabant in different doses. Naltrexone, an opioid antagonist, has been tried to see what are the effects of using these and whether they can be used in the well-designed, larger randomized control design or not. Similarly, agonists on cannabinoid receptors such as dronabinol in different doses, different kind of regime, they have been tried. We can see the number of participants here is really modest, really small, because these are those kind of studies. People have tried quintilone also, cannabidiol also in the similar fashion, and a wide variety of antidepressants, bupropion, nefazodone, mirtazapine, and so on. People have also tried divalproex, quetiapine, baclofen, you name it, and people have tried to see whether this can work or not for cannabis dependence. So this was just to show an idea how people have tried to approach development of pharmacotherapy of a cannabis dependence. Now, in general, to summarize all the RCTs for cannabis dependence, I thought it would be much more cost effective if I just give a highlight of this very recent last year Cochrane review on pharmacotherapies for cannabis dependence. A very good quality Cochrane review, systematic review, which was published recently last year itself, with 21 randomized control trial, very carefully searched and selected, and a very decent size, about 1,755 participants across all these RCTs. They included a variety of studies, including both inpatient and outpatient, excluded studies which were focusing on schizophrenia, participants also with cannabis dependence syndrome, as they clearly specified, or who are likely to be dependent. So, in general, in terms of quality of the evidence generated from this systematic review is very good. Primary outcome also, as we can see here, are the traditional standard outcomes for any kind of drug dependence treatment trials. Abstinence, intensity of withdrawal, adverse effects, and so on, as well as treatment retention. These are the medicines which they found out, which they actually found out on which the RCTs were conducted. There were preparations containing THC, such as dronabinol, with or without in combination with lofexidine. SSRIs, a wide variety of SSRIs have been tried for this condition. There are mixed action antidepressants such as nefazodone or mirtazapine, venlafaxine, bupropion, buspirone, atomoxetine, and some of the mood stabilizers, valproate, gabapentin, lithium, and so on, and acetylcysteine, one of the promising and for a very long time promising agent for treatment of cannabis dependence. So RCTs were conducted on various of these, and now let's see what they found out. To summarize their findings about preparations which contain delta-9 THC, the typical agonist approach, they appear to effectively suppress cannabis withdrawal and craving, but not necessarily associated with reduction in cannabis use or treatment reduction. If you add some adjuncts such as lofexidine, they may enhance the effectiveness of THC preparations in reducing the withdrawal and improving sleep. And it's possibility that effectiveness may vary with type of THC preparation. Similarly, for SSRIs, a clear conclusion appears to be that they do not appear to affect cannabis use, withdrawal, or treatment completion. For mixed action antidepressant, they may be of value in treatment of depressive symptoms, but they do not add much value specifically for treatment of cannabis dependence. For mood stabilizers, the quality of evidence is again low to very low. Gabapentin, but not valproate, had some capacity to ameliorate cannabis withdrawal. Lithium affected only some cannabis withdrawal symptoms. Similarly, topiramate also, but then there are side effect issues with topiramate. Buspirone may be useful for treatment of anxiety, but otherwise nothing for cannabis dependence as such. Bupropion, some effect on cannabis withdrawal, but data inconclusive on other outcomes. For atomoxetine, it may be useful for treatment of ADHD if it's comorbid, but little value in treatment of cannabis dependence per se. And acetylcysteine, as I was saying, it has been generating a lot of interest for a long time now. It shows some effectiveness in the treatment in young adults, but data cannot be seen as conclusive as yet. For oxytocin, there is only one small pilot study on intranasal oxytocin, and perhaps much more research using this particular agent is warranted. So the overall conclusion, which came from this very systematic review of all the RCTs, is that in general, for all the pharmacotherapies evaluated so far, the evidence appears to be rather incomplete. We must now put a full stop to use of to the question whether these agents work or not. SSRIs, mixed action antidepressants, bupropion or buspirone, they add little value. About THC preparations, some promise. There are some positive effects certainly on withdrawal and craving, and which is really intuitive. One can assume that, but they are still largely experimental, and perhaps more research should continue on this. About gabapentin, oxytocin, and N-acetylcysteine, the evidence so far is weak, but they certainly warrant much more further investigations and trials. So as we can see here, the quest for finding an effective medication for treatment of cannabis dependence continues. What does our own Indian evidence, though it's 2015 IPS guidelines, what does it say? IPS guidelines also suggest that evidence for drug treatment is still preliminary. They suggested pharmacological treatment should ideally be used in combination with psychosocial interventions. And on the basis of evidence which was available till then, 2014-15, it was buspirone, baclofen, fluoxetine, and acetylcysteine were the kind of agents they suggested, and a wide variety of psychosocial interventions were recommended, such as motivation enhancement, CBT, or their combinations. Of one particular interest, one approach which I would like to quickly highlight is this: FA inhibitors, fatty acid amyl hydrolase inhibitors. What these agents do is that they inhibit this particular enzyme, fatty acid amide hydrolase, which then increases the level of endogenous cannabinoids such as anandamide by preventing its breakdown. So more anandamide is available at CB1 receptors in the brain, and hence some of the symptoms like withdrawal or craving seen in cannabis dependent individuals, they perhaps will be ameliorated, they perhaps can be managed. So this is really a promising kind of approach. The problem is the toxicity and many other kinds of side effects with FA inhibitors. So there is one particular trial with one experimental agent published just about 2 years back, the randomized control trial, not very large scale, just around 40 odd individuals, but they did found that over a 4-week treatment period, it reduced cannabis withdrawal symptoms and cannabis use in men, and might represent an effective and safe approach. So the concept which has been brought about perhaps requires much more proof in further more robust randomized control trials and better studies. So as I was saying, the quest continues. We are reaching the conclusion now. What is my fantasy treatment for cannabis dependence? I actually fantasize about a kind of molecule which is somehow generated, preferably a derivative of cannabis plant itself because of the cost and economic and various other policy issues. The molecule must mimic some of the psychoactive properties of cannabis. So perhaps some of the reinforcing or mild euphoric properties can be mimicked, but memory dysfunction or spatial disturbances, perceptual distortion, those should be either absent or present to the minimum degree in this molecule. Molecule should be orally active, which is very imperative. And ideally, it should be available in different kinds of formulations. So for a maintenance kind of treatment, just like we do for opioids, once a day treatment, it should be a sustained release preparation. But then we know typical cannabis people who use cannabis, they have some situations where they need to experience the psychosocial, the psychoactive effects. And perhaps the immediate release formulations of this fantasy molecules could be useful for those situations where people need those effects, perhaps to calm their minds, perhaps to enhance their creativity, or whatever other reasons people use cannabis for. Till then, I think this search continues. To conclude, usually in conclusion, people offer some solutions, some final words. I am leaving this group with some questions in the conclusion. Where exactly I think are we going wrong with finding treatment of cannabis dependence? Why even after spending billions of dollars in USA particularly, we haven't been able to find good treatment, pharmacological treatment for cannabis dependence? Could it be because we are treating the wrong condition? We may recall till few years back, it used to be actually debated in many circles whether cannabis actually produces dependence. Does cannabis dependence actually exist or not? Now, of course, with a wide variety of research, with DSM and ICD both providing us the diagnostic criteria and so on. So yes, the entity called cannabis dependence does exist, but we know from clinical experience as well, through research as well, that what we typically see with other psychoactive drugs, tolerance, severe withdrawals, are not the distinctive features of even the so-called cannabis dependence. Also, one must remember, in many cases, uh, even if so-called cannabis dependence exists, does it warrant active, aggressive treatment in all cases? We have already shown public health kind of data, which shows perhaps the burden of disease caused by the entity called cannabis dependence is much less as compared to other kinds of drug dependence. So the severity is much less. Does it really require such aggressive treatment? Many of us in our clinical practice also see quite a few patients, young adult men, perhaps college students or just early in their careers, and brought mainly by their parents complaining that they are using cannabis along with various other behavioral symptoms, misbehaving with parents, showing in general irresponsibility, showing more interest in other activities and hobbies, and not pursuing their primary occupation or profession or so on. So perhaps the treatment there is being looked for. What the parents or family members are seeking treatment for is that overall constellation of behavioral symptoms and not just cannabis dependence there. And in the same light, are we treating the wrong symptoms here? If we see these all drug trials, the outcome has been typically whether cannabis use was reduced or not, whether urine cannabis concentration was reduced or not, whether patients noted themselves to be abstinent or not. Is abstinence the ideal treatment outcome for cannabis? A question worth seriously asking. Perhaps the functional outcomes, quality of life, reduced complications of substance use, are they much more viable outcomes for all kinds of substance dependence, but perhaps more relevant for cannabis use disorders? Something to think about. Also, I think since now there is increasing acceptance of cannabis use globally. Why I am saying this? Many countries are actually legalizing it. In many other countries, if they are not legalizing it, they are at least decriminalizing it. So the lens with which other illicit drugs are seen is now different for cannabis. So in view of this much more acceptance, perhaps the research focus also should move from this very obsessional seeking of abstinence from cannabis use as the only treatment outcome to other kinds of approaches as well. Perhaps research should be conducted on safer modes of delivery of cannabis, because as we know, people are consuming cannabis through smoking route. We know it's harmful, it's dangerous. Safer ways of consuming cannabis, and perhaps less harmful models of cannabis market. The full corporate model which is exists for big tobacco or big alcohol, is it the only way to go about for cannabis also? So these are kind of the issues which also deserve our attention, and not just that obsessive search for an agent which, when given to an individual, results in magical stopping of that person's cannabis use. With these questions, I am leaving all of you, ladies and gentlemen. Thank you very much for your kind attention. I will very shamelessly plug in our Addiction Psychiatry Society of India. Urge everyone to visit our website and apply for membership. I'll be happy to interact and respond to some of the questions. Thank you very much, organizers, chairpersons, and the moderator.
Thank you, Dr. Atul, for a wonderful presentation, and it was clear, lucid, and comprehensive. And you left us many questions that we should actually ask ourselves in relation to cannabis dependence. I would like to now hand over to the chairpersons for their brief comments, after which I will take the questions from the audience. Chairpersons, please, if you have anything to add.
No, I think Dr. Atul has very deliberately took all the areas of related to cannabis, and I think his last slide was very important, that whether it is an addiction or not, and if it is an addiction, then how it can be made more relevant for the population, so that they can enjoy the cannabis and avoid the side effects. But still, I think he covered all the latest areas which I also undergone about the cannabis dependence, but I am finding that he has very meticulously placed all the things at their place, and I congratulate him for the very successful oration. Thank you. Thank you very much, Dr. Atul.
Dr. Sanjeev, any comments?
It was a very lucid presentation, giving all the details and all the multiple views about the thing in a very nutshell. There are lots of debates and lots of different opinions about the topic for a very long period of time. Whether there is physical dependence, whether there is psychological dependence, whether there is only habit forming, not dependent, and all sorts of discussions like that. Uh, One area which is not particularly focused and which is not related to psychiatry as such is like if we say rice, it differs from country to country. Even in India, we have basmati rice, we have that different types of rice, biryani rice, this rice, that rice, and the properties differ. So that cannabis in India, which is grown, is different from cannabis which is grown in other countries. And whether it is less addictive and that is more addictive or something like that. So I think we'll invite questions with that from the audience. I I request our moderator to go through
Yes,
the
thank you.
questions.
Thank you. I'm going to start asking. There are lots of questions, so I would start. I think I'll set the ball rolling and ask Dr. Atul, what is the current status of cannabis as a gateway drug? Because this is one of the major reasons touted by people to so-called not legalize or not decriminalize cannabis use because it leads to addiction to harder drugs. So, what is the latest status of cannabis as a gateway drug?
Thank you very much for asking this question. What we need to understand is that first we need to properly put the perspective of this term gateway into its right place. Gateway may mean different things to different people. For most people, the simplistic understanding of gateway is having a temporal association. So in the sequence, it's one thing comes first, it becomes the gateway to the next thing. And since people claim that people start with cannabis and then some of them go on to use opioids, cocaine, or amphetamines or other kinds of harder drugs, then perhaps cannabis should be regarded as the gateway drug. If this sequence is only something which was of interest to us, the biggest gateway drug is actually coffee, right? Everyone starts using coffee, and then at some point in time, they start tobacco or alcohol, and some of them would start using cannabis and move on to other kinds of harder drugs. The reason why we see such temporal association in some individuals is because cannabis has been grouped together under our laws and policies with all other illicit drugs and substances. And since we have created that different place, that different market for all illicit drugs, there is no surprise that someone using one illicit drug get exposed to a much more expensive, a much more so-called harder illicit drug also in that same market. Uh, that's the kind of answer to people who see this perspective only from the epidemiological studies or this casual kind of observation. Truth is, most of the longitudinal studies as well as the epidemiological data has failed to provide good evidence that cannabis use actually in biological terms or even in social terms primes an individual user for using other kinds of harder drugs. So today the consensus is shifting largely from the gateway hypothesis to the CLA hypothesis, common liability to addictions, which means people have biological vulnerability for different kinds of addictions, and because of various environmental factors, this vulnerability to addictions gets manifested in form of various kinds of addictions, including some of the behavioral addictions as well. So that's the present understanding of gateway hypothesis of cannabis. This rejection of gateway hypothesis is in fact the reason why many countries are moving towards legalization of cannabis. Because once it's legalized, it's unlikely that the same person who sells you cannabis will also sell you cocaine or heroin. Just like what happens with
Hmm.
alcohol today, right?
Yes.
You don't get illegal drugs in the typical alcohol theka. So that's the philosophy there.
Okay, thank you, Dr. Atul. There is one comment on your talk and by Dr. Rajesh Nagpal, and I think you can respond to it. I'll read it out. Dr. Atul, your argument that cannabis dependence as an entity is questionable, and this questioning of dependence reveals obsessive nature of the therapist, is a dangerous one.
Yeah. Okay. Perhaps this requires a little bit of elaboration. I did explain this also. I was merely hinting to the fact that uh, the severity of tolerance and withdrawal symptoms, which we see with many other drugs of dependence, is not seen so severely in cannabis. So that's why what we typically see as physiological dependence is not so prominent with cannabis. But as I also pointed out in my talk, cannabis dependence is a very well recognized entity, both in DSM and in ICD. So cannabis dependence does exist. The issue is this level of dependence. Does it convey the same degree of severity and same degree of public health importance? That's the question we should be asking. And the available public health data does indicate that in terms of severity of dependence, as well as in terms of contribution to the global burden of disease, cannabis contribution, dependence contribution is much less as compared to other drug dependence. So the point here is being made in terms of prioritizing at a public health level. So if a government has to put money in research on finding good treatment, where should that first dollar go to? To finding good treatment for alcohol dependence and heroin dependence, or for cannabis dependence? That the kind of question will be answered through this kind of public health approach. And that's the only limited point I was making there. Not questioning the existence of cannabis dependence as such.
Okay, thank you. There's a question by Dr. Yujal Man Singh. What is the evidence for brief intervention in the treatment of cannabis dependence?
In the field of cannabis use disorders, much more research has been conducted with the variant of brief intervention, much more intensive variant of brief intervention, which we know as motivation enhancement therapy. There is some evidence for brief intervention as well, which has been found good for motivating people to seek more organized and formal help. So, in fact, the WHO, when WHO developed ASSIST as the screening tool and combined it with brief intervention, the first two substances which they targeted were nicotine, tobacco, and cannabis in primary care for brief intervention. And the endpoints there were not so much abstinence, but engagement in more formal treatment process. So there is some evidence that yes, brief intervention can work in motivating people to help them go for much more formal treatment. By themselves, brief intervention as with abstinence as the endpoint or at the outcome, the evidence is good.
Thank you. Next question is by Dr. Anukant Mittal. Should we attempt to treat? Where is the illness? Meaning that should we actually even attempt to treat?
This is more of a rhetorical question in the line of the kind of questions that I was also raising.
So I think you already answered some of the parts we can go to.
No, I will just quickly say that perhaps many times it's the overall constellation of various other kinds of behavior which the family members are bothered by, which deserve attention and not just cannabis use.
Any evidence of, Dr. Gurvinder Pal Singh has asked, any evidence of cannabinoids as therapeutic potential in neurodegenerative disorders?
Out of course, but yes, some research is being conducted for use of cannabinoid medications for various neurodegenerative conditions, for multiple sclerosis, and so on.
Okay. One question is by Dr. Suraj Singh. Of course, again, this is not related to treatment. So would you like me to ask questions only based on what the topic of this webinar is, or because his question is how can medical marijuana help cancer patients? So this is really out of the syllabus, as you say, curriculum of this webinar. So we might try and avoid those questions. Now, what is the Dr. Sanjay Kumar Jain has asked, what is the pharmacological option for reducing craving in cannabis use?
Right. So basically, the endpoints of treatment have very often been whether person has used cannabis or not. If we want to use a particular agent as reducing craving, then the endpoint actually should be reduction in craving scores. irrespective of whether person has used cannabis or not. So on that kind of parameter, the THC agonists have been found to be very promising in combination, particularly with lofexidine.
Thank you. Next question is, what are there any managed by Dr. Challa S.V. Krishna, management of options for amotivational syndrome with cannabis dependence?
Right. Amotivational syndrome is again a very, I would say, controversial entity. People have also questioned its very existence. People have tried to explain it by adopting a particular kind of lifestyle associated with that cannabis using subculture. So a specific pharmacological treatment for amotivational syndrome actually does not exist.
Thank you. What would be, this is Dr. Karishma Rupani has asked, what would be a drug of choice in those with conduct disorder and cannabis use disorder and the rationale? So,
I'm not sure of this comorbidity. I mean, whether we are treating here conduct slash ASPD or we are treating cannabis dependence. So, I mean, there is such no medication which can effectively take care of both of these things simultaneously. The available evidence also indicates that whenever medications are used which are effective for conditions such as ADHD, then they are good in treating ADHD without showing efficacy for treatment of cannabis use disorders per se.
Dr. Rajesh Nagpal has asked a question. In clinical practice, less than 20% experience withdrawal symptoms. What would be the possible neurobiological basis for this differential experience? Why very few people have real withdrawal symptoms as we understand it?
Yes, that's the nature of endocannabinoid systems, sir. Endocannabinoid systems are not associated with uh, distressing or serious withdrawal symptoms, which may be physiological or psychological in nature, which one sees in alcohol or opioids. So that's how the nature has designed this system.
Uh, there's a question by Dr. Arnab Datta. Sir, how to incorporate the cultural approval of cannabis into therapy, as often it turns out to be a dead end in change talk, especially in high-risk patients like past history of induced psychotic episode or family history of psychosis. Also, will liberalizing cannabis use or easing sanctions by policy increase the effect of the psychotherapeutic barrier?
I think it's a very relevant question. People have, in those areas where cannabis is being legalized, people have grappled with this question, whether this is going to increase the incidence of psychosis. Particularly, the psychiatrists everywhere in all those countries also have been concerned with this particular phenomenon. So far, the evidence does not very strongly suggest so that legalization of cannabis has resulted in increase in cannabis induced psychiatric conditions or cannabis induced psychosis. But this is at a larger policy or public health level. For individual patient, whenever there are talks in favor of more liberal approaches to deal with cannabis, this question is going to be a challenge. This question is going to haunt us. In my own practice, I have been confronted with these issues where people, some of my patients themselves, have seen as some of the debates, ongoing debates, and have confronted me with these. Why can't I use cannabis when government is legalizing it in Canada and so on? So there, in terms of psychoeducation to our patients, very important for them to explain the individual variations in vulnerability for various kinds of substances, including various kinds of living conditions themselves. The similar kind of weather, may have different implications and different effects on different individuals. Similar kind of diet or food habits may have different results in different kind of individuals. So you happen to be one of those individuals who are particularly likely to be susceptible or vulnerable for some ill effects, for some adverse effects of this particular substance. So that's the kind of approach one can adopt while psychoeducating patients. But you are very right. The liberalization does send out a message, inadvertent message, that we are talking of a totally harmless or safe product here. That is not the case. It's not the case that it is a harmless product. It's the only debate wherever is occurring about cannabis is about just how harmful it is. Not harmless, but just how harmful it is. So that's the kind of creativity perhaps we mental health professionals will have to adopt while dealing with our patients.
Next question is, any role of harm reduction approach in cannabis dependence syndrome by use of low potency cannabis derivatives? And I would like to extend that question by asking also do you think adequate doses were used by these in these trials of agonists, which could actually help suppress craving and withdrawal? Or do you think the doses themselves are not adequate? Or why not use some derivatives of the plant itself rather than a particular chemical?
All good and very relevant questions. I'll come into the dose issue first. Yes, that's a very pertinent one. But then, if the doses were perhaps inadequate, then one would expect poor control of withdrawal or craving as the end result or the outcome. Actually, the results have shown that the craving or withdrawal scores, they were controlled very well. What did not reduce is actual usage of cannabis. So that's the point I was also making, that our outcomes, if they depend upon whether तुम्हारा cannabis use कम हुआ या नहीं या stop हुआ या नहीं, then we are talking of a different kind of paradigm there. So that's about the dose issue. About harm reduction, yes. Now I'm just digressing. I will just digress a little bit here, but it's relevant here that there is something called as iron law of prohibition. Iron law of prohibition actually states that more a substance is made illegal or prohibited, its more potent forms will be trafficked, marketed, and used. Alcohol, people typically see, if alcohol is prohibited, people don't drink beer. Those who drink, they drink whiskey or other kind of potent stuff. People expected this for cannabis also. However, whenever cannabis is being legalized in those markets, people constantly see till now that the potency of available in terms of THC concentration has been increasing in cannabis products. So for harm reduction, it would actually be it will call for very active efforts on the part of authorities to control the kind of cannabis products which are available in market in terms of dose. And finally, the issue which I was raised also, the legalized cannabis wherever it has been occurring, it does not solve the question of route of intake of cannabis. If people are still using it by smoking route, and smoking route is, we know, is much more harmful than other routes. So perhaps work should more actively be conducted on developing oral forms of cannabis consumption. What they are doing in Western countries with cookies or brownies or candies, the edible cannabis, problem is THC concentration is perhaps higher than desirable in some of those products. And secondly, whether they are taking adequate safeguards to protect children's access to these products or not. That's another important issue which policymakers in those countries need to deal with. So I certainly see a lot of potential for harm reduction approach to be applied in the area of cannabis. But for that, then again, this focus on abstinence as the only desirable end point or outcome need to be sort of dealt with.
Thank you. Dr. Soumik has asked a question. How frequently does cannabis-induced psychosis occur in clinical practice from your experience? Because I think this is an important point when psychiatrists themselves tend to be a little reserved about addressing the question of legalization and
Yeah,
decriminalization.
yeah. So it's actually the typical fallacy of all clinicians, which psychiatrists also sort of face, that we actually see the like all clinicians, like all doctors, we actually see the people with the on the severer end of spectrum. So cannabis, we see in our practice quite frequently cannabis-induced psychosis type of presentations, but then it's natural. There are very few psychiatrists in our country. There are very few mental health professionals in our country, and people with psychotic symptoms, psychotic illnesses will more often than not end up with one or the other psychiatrist. So that's why it's natural that we will see those patients. And in clinical practice of typical psychiatrists in India, I would say cannabis associated psychotic conditions will be very common. Will they be very common in community as well or not? That's a different issue. That will depend on many other factors. Even from the times of Indian Hemp Commission, when the British government conducted that large-scale study in India of effects of cannabis, the conclusions has been that yes, in a subset of individuals, use of cannabis is associated with mental disturbances, but perhaps it's people who are already vulnerable to these mental disturbances. In those, we see these manifestations. So, cannabis-induced psychiatric conditions, including psychotic disorders, are much common in a typical practice of a psychiatrist, but their community prevalence is not very high and will not high to alarming proportions, at least with the available evidence. Uh, if the if there is change in the regulatory status of cannabis.
Thank you. Dr. Puneet has asked a question. Any specific suggestions or precautions while treating cannabis dependence in different age groups like adolescents, females, geriatric age group? Are there any specific suggestions?
Right. Particularly for adolescents, I am much more, for instance, I mean, my attitude is slightly different when I deal with adolescents as compared to adults who are more or less settled in their lives. Because of adolescence, because of the growing nature of their brain and their personalities, any kind of acceptance or tolerance of substance use perhaps is not a very good idea. So one needs to have in my practice, at least I do have a very have a much more abstinence oriented focus for when I'm dealing with adolescents patients with cannabis dependence. Similarly, women of childbearing age, largely because of consumption of cannabis through the smoking route, it's a no for women, particularly in their who want to be on the family way as well. So these are some of the issues I sort of try to look after in my clinical practice.
Thank you. There's a question by Dr. Gurvinder Pal Singh. Why adolescents with cannabis dependence are more cognitive dysfunction in adult cannabis dependence patients?
Yeah, perhaps the brain is much more susceptible to the cognitive effects of cannabis. Uh, there is some evidence for this on functional imaging studies as well, how the cognitive functions in adolescents using cannabis are affected. So perhaps that's the reason.
Okay. I'm deliberately avoiding questions related to cannabis legalization and decriminalization because that is not the mandate of today's webinar, and that would,
I mean,
unless,
much as we like talking
yeah,
about it, that's not what Banai has
correct.
asked us to do today.
Yeah. So, Azhar has asked the question, are there any ways to counteract the negative effects of marijuana use? So it's a very general question, not specifically about what the negative effects are, but you can take this up as a general way.
There are people who complain that increased appetite with cannabis is a concern for them, because then they weight gain problems, they experience weight gain problems, and hence they themselves try to change their lifestyle and modify their lifestyle around it. Driving after using cannabis is strictly no. Similarly, all kind of operating heavy machinery or any kind of activity which can pose individual, which requires more hand-eye coordination and may result in accidents, must be absolutely avoided. These are some of the advices I give to my patients who are not willing for abstinence.
Thank you. Dr. Jasminder has asked a question that Dr. Ambekar, due to a lack of scientific evidence, no drug has been approved till date for the treatment of cannabis dependence. And because of this, psychotherapeutic techniques continue to remain the foundation of treatment. Do you agree, and would like to know your views on this?
Yes, absolutely. That's exactly what I also try to explain in my talk. That when the most treatment guidelines are suggesting psychosocial intervention as the mainstay, not because we have got very great effect sizes or outcomes with those psychosocial interventions. It's largely because we don't have very good pharmacotherapeutic agents which can show effectiveness. So as a last resort type of option, psychotherapeutic interventions have been recommended by guidelines. But it's not that they have very great abstinence rates as well. And good psychotherapeutic interventions are actually quite expensive also.
Mm, thank you. Any role of injectable naltrexone in serious cannabis dependence syndrome?
Not to my knowledge or understanding. Naltrexone oral itself has not been found very effective. Though I use it in clinically in some of my patients with decent kind of results. In some patients it worked, in some patients it didn't. But injectable naltrexone specifically for cannabis, no great evidence there.
Okay. Dr. Siddharth has asked, what are the uses of CB2 agonist and antagonist? CB2.
Come again, I
What are the
uses
uses
of
of CB2 and agonist or antagonist? So,
for not for the purpose of cannabis dependence syndrome.
correct.
If at all, they will have some role in other kind of immunomodulation, etc.
Mm, just a minute. I'm just scrolling through the questions. What to expect during treatment of a pregnant woman with cannabis dependence, effects on pregnancy, fetus, breastfeeding, long-term cognitive effects on child. So,
Right. So there is some data that there may be cognitive defects in children born of mothers who were using cannabis while pregnant. Though very clear-cut evidence of teratogenicity or organ malformation, like one sees with alcohol of those fetal spectrum disorders, those are not known with cannabis. But other than that, there may be more to this area, which I am not sure of.
thank you. Um, question by Dr. Sachin is that he's not specified exactly, but does maturing out occur with cannabis use like with heroin?
Yeah.
Meaning probably
Yes.
whether
Yes.
the use reduces with
Yes.
age.
Yes. In fact, spontaneous remission of substance use behaviors is much more well documented with cannabis as opposed to heroin or cocaine.
Okay. Uh, Depression and cannabis, this is by Dr. Neha. Depression and cannabis amotivational syndrome have many overlapping symptoms. Can we use antidepressants as treatment for amotivational syndrome?
Yes, in fact, most of the drug trials which have used various kinds of antidepressants for cannabis use disorders, they have found good outcomes in terms of reduction in depressive symptoms. So whether or not cannabis use gets affected by those antidepressants or not is a different issue. But if there are depressive symptoms present, then they certainly can respond to those antidepressants.
Okay. Um, okay, this is more of a policy question, but why pro-cannabis drive in and media in recent time? Obviously referring to the recent developments in certain cases and all of that. So why pro-cannabis drive? I mean,
Right, right, right.
meaning probably
I would want. I mean, there people can be pro or con for various reasons, including for their own vested interests, including some of the ideological positions that they may have, including their own understanding of science. One needs to be is actually not pro cannabis or anti cannabis. One needs to be pro health and welfare of humankind. That's what I would say. And in general, if people are pro health and welfare of humankind, they will support those kinds of policies which reduce general harm to the population and which improve population's health. So that's the kind of lens with which one needs to look at this particular issue. So if you are talking of things in Indian media, this is the kind of approach one needs to adopt. Whether the kind of approach they are adopting, are they good for public health and welfare or not?
thank you. One last question before we come. Zishan, I think the webinar ends at 9:30.
Yes, sir.
Zishan?
Yes,
Yeah.
sir.
So I will, it's already 9:22. Uh, Maybe one or two questions further. And Dr. E. Mohandas has said, Dr. Atul, I had a patient who sustained post-traumatic epilepsy during his motorbike exploits in a globe, around the globe. He was a cannabis abuser. He had relief from his epilepsy. My advice was to continue cannabis as he could not get good response from other anti-epileptic drugs. He is still in the circus continuing his exploits. Dr. Mohandas.
Interesting comment and interesting anecdote actually uh, for all of us to learn from.
Uh, Dr. Abdul Majid has asked a question. Shall comorbidity be diagnosed after 4 weeks of abstinence in cannabis as well, since it has much longer half-life? And in many patients, effects of cannabis last much longer as compared to other substances like heroin, etc.
Yeah. So, in general, for any substance, one tries to make diagnosis of whether independent slash induced after a reasonable period of abstinence has occurred. With cannabis, it makes sense to for that this period to be long, as long as possible. So 4 weeks sounds like a reasonable kind of time period. One must also remember the kind of flashback phenomena may occur with cannabis, and hence some quasi-psychotic type transient symptoms maybe because of result of that phenomena in some people with cannabis use.
Okay. So this, I think you've answered another question similarly by Dr. Siddharth. about flashback phenomenon in cannabis use, which you already alluded to. Okay. How, Doctor? Second.
Hello.
Hello. Yeah. So 1 second.
Yeah.
Dr. Ashwin, can you repeat the question again?
Which one?
You whatever you asked right now.
No, no, I'm not. I
No,
didn't
he
ask any
didn't
question.
ask.
I didn't ask a question. I was just
Okay, so
scrolling through the.
I would like to announce the jury to announce the winner for the best question. If we are done with the question answers.
Yeah, I one last question, and then I think the chairpersons can announce the winner, I guess.
Okay, okay.
Yeah. So one last question. Dr. Ashish has asked, what is the role of multi-criteria drug harm assessment process, MCDHS, methodology in policies of cannabis use?
Uh, that's basically you are talking to what extent science influences policies about psychoactive substances. Very little, my friend. But yes, the multi-criteria decision that you are referring to from the group of Dr. David Nutt from UK has actually laid the foundation of showing to the world how the public health harms can of various psychoactive substances can be arranged in a hierarchy, and how cannabis figures much lesser, much lower in that list as opposed to legal substances even like alcohol and tobacco. That, along with various other factors that we cannot go into for paucity of time, has resulted in this really changing stance of various governments towards cannabis, which is actually correcting many of the historical wrongs. But as I said, we can't go into that. But yes, that kind of research paradigm, that kind of way of conducting research could be useful for advocacy and for policy making.
Thank you. So I think we answered most of the questions. Some of them were repetitive. Uh, uh, what I would like to, I'd like to give the mic to the chairpersons to announce the winner of this best question for today's webinar, an Amazon gift voucher for a huge amount of 5,000 rupees, and some lucky winner will be announced by them. Over to the chairpersons.
I would like to thank the moderator for the excellent moderation, as well as
Thank
the
you.
respected esteemed chairpersons for chairing the session and giving me the encouragement. Thank you very much.
Thank you. Dr. Ravi and Dr. Sanjeev, Amita or Zishan, will you be flashing the question on the screen, or how would
Yes,
you like to?
yes. Amita is sharing the screen.
In the meantime, congratulations, Dr. Atul. A wonderful presentation and wonderful interaction also.
So the question is flashing.
So, Dr. Ravi, you can announce the
Yeah.
winner.
Yeah. The winner is Dr. Arnab Datta. And
The
The
question.
question.
sir, how to incorporate the cultural approval of cannabis into therapy, as often it turns out to be a dead end and in change talk, especially in high-risk patients like past history of induced psychotic episode or family history of psychosis. Also, will liberalizing cannabis use or easing sanction by policy increase the effect of psychotherapeutic barrier? This was the question.
Thank you. So I thank all the participants before handing it over to the chairpersons for their final comments. I'm thanking Dr. Atul Ambekar for an excellent talk, all the participants for a huge number of questions which were there, and the organizers for inviting me to become the moderator of this session. Thank you so much. Now I hand over to the moderators, after which they can give it to the organizers and to the chairpersons, after which they can hand over to the organizers. Thank you so much, all of.
Thank you.
Yes, we should conclude. It was really a fantastic, at least 1 hour, past 1 hour. We enjoyed the presentation and we enjoyed the interaction also. We have fantastic questions. It was very difficult to decide the best question. And there were, very eminent personalities also asking the questions. So it was a difficult task. Hmm.
Yeah, certainly it was a very difficult task, but with the help of two of the chairpersons and the moderator, we somehow decided the prize-winning question, and really it was very informative, and all the aspects and the future aspects were also discussed, and the positive aspect of cannabis was also discussed. So I'm very thankful to Dr. Atul that he prepared very nice slides and increased our knowledge about the cannabis and the treatment facilities which are available with us. So thank you to all the audience also that they interacted very actively, and a lot of questions were there, which were many questions were very relevant and very interesting. So I with Dr. Saoji felt difficult in organizing the WhatsApp group which we were handling together. The program helps us in finally giving our opinion about the best winning prize. Otherwise, it was very difficult. Thank you, Dr. Atul, for a very nice presentation. I thank Dr. Saoji, who helped me in conducting the session, and I am grateful to Dr. Ashwin also, who moderated the session very well, and the question answer session were also done very well.
And
Thank
thank you,
you.
Banai.
Thank you.
Thank you all of you, sir, for joining us
Thank you
today.
all.
Please block your next date. Block your dates every Tuesday, 8 p.m. to 9:30 p.m. All interested topics will be coming up every week. Next topic for next webinar is OSA in psychiatric practice, barely recognized, rarely treated, by Dr. Ravi Gupta on 12th Jan 2021. Do send us your
Fantastic.
feedback and comments on info@medisquare.com. Till then, stay safe. Good night. See you all
And
next week again.
Zishan, before ending, I would like to encourage everyone to visit the Addiction Psychiatry Society of India website and enroll and become a member of APSI. And I'm sure it will be worth your while. Thank you.
Thank you. Thank you again.
Thank you. Bye-bye. Good night.
Good night.
Thank you. Bye bye.